Good evening, everybody. Today, we are here to hear from Dr. Rena Patel on challenges and opportunities at the intersection of maternal and child health and HIV. So before starting, I would like to tell you who Dr. Rena Patel is. Dr. Rena Patel is an associate professor in the Division of Infectious Disease at the University of Alabama at Birmingham here. She holds a medical doctorate from San Francisco School of Medicine and a Master's of Public Health from Harvard University School of Medicine, School of Public Health, and also a Master's of Philosophy from the University of Cambridge. Dr. Patel is a board certified in internal medicine and infectious diseases after completing her fellowship in infectious diseases from University of California, San Francisco. Her research focuses on HIV, infectious diseases, women's health, pediatrics, and health equity. She employs mixed methods of research, and including clinical trials, cohort studies, big data science, and community-engaged research. Her work has been recognized with numerous awards, including the NIH Career Development Award and the University of Washington Chair of Medicine Scholars Award. Before moving to UAB, she served as assistant professor at the Division of Infectious Diseases at UCSF, San Francisco, California, and also at the Division of Allergy and Infectious Diseases from University of Washington, Seattle, Washington. So in addition to her academic career, Dr. Patel served as attending physician at Harborview Medical Center at the University of Washington Medical Center. She's actively involved in mentoring students and fellows, particularly those from underrepresented communities, and has a strong commitment to equity, diversity, and inclusion in her professional and personal life. Dr. Patel has published extensively in peer-reviewed journals and has been invited to speak at national and international conferences. Her dedication to improving health outcomes for marginalized populations is evident in her leadership roles in various research projects and also community initiatives. Her CV is very extensive. We can't go through it all. However, Dr. Patel will be able also to talk to us about her personal experiences that is also linked to the topic we're going to discuss today. Thank you, and let's welcome together Dr. Patel.
Thank you, Brian. I really appreciate that. That's more than I would have said myself, so thank you. In the interest of time, we will get started. Okay. And I want to make sure to have enough time really for questions and answers session so that this is a good use of your time to think through what you're interested in, what you've been thinking about. So this is the outline of what I'll talk about today. In regards to acknowledgements, first a land acknowledgement, that the land which we live and work on is traditional ancestral land of the Muskogee and Shawnee people. Here's a website link for those of you who might be interested in incorporating land acknowledgements in your work. Thank you to MCHSA for this invitation. All the collaborators who work with me, and the list is so long that I didn't have a chance to include every single person or picture in here, and the funders who allow us to do this work. Couple disclaimers, no conflicts of interest. The views presented today are my own personal. They do not represent the views held by UAB. In terms of background, maternal child health and HIV are quite intricately linked. So the treatment of HIV for a woman not only impacts her individual health, but also has risk of vertical transmission when she becomes pregnant. So globally, it's estimated that 1.2 million children are born to women living with HIV annually. There's a specific guidance document for the global elimination of vertical transmission for this reason. And increasingly closer to 90+% of women are on antiretroviral therapy, which is the treatment for people living with HIV. Uh, Yet, up to a third of the women are not virally suppressed at some point during the pregnancy or postpartum period, which is defined up to 24 months postpartum. So another element is that, HIV medications used in these therapies are causing exposures to the babies, infants in utero, and afterwards through breastfeeding. And this applies for pre-exposure prophylaxis, which is to prevent HIV. So both on the treatment and HIV side, we have to think about this. The burden is largest in low middle income country, and furthermore in Eastern and Western Africa. So here you can see the number of people living with HIV from 2017. Most of the 37 million people are in Eastern Southern Africa, and 60% of those are estimated to be women and girls, and a large number of those who are in treatment are also women and girls. So what I wanted to do was start taking you through sort of a potpourri of different projects and studies that I've had the good fortune to be involved with that have to do with maternal child health to demonstrate some of the challenges and opportunities. And so I'm starting with a study called Op4Kids. And this study is important because viral suppression for HIV, which is when you give someone treatment, you're expecting the virus to be undetectable estimates. And it's not clear what is the best way for suppressing the virus and maximizing treatment options. And the additional issue for children is that they have very limited treatment options compared to adults. So adults have far more medications that have been tested and approved for use in them. They have sort of a standard dosing that's applicable to most people or most situations. But children, as you can imagine, you're going all the way from a newborn baby up to a 14-year-old. Starting at 15, we tend to use adult doses with children, but up to 14 years old, it's a huge range. And not all medications, even if approved for children, are available as formulations for that age or weight group. So particularly challenging. So when we have medications available to children, we need to make sure we maximize them and they don't become susceptible to drug resistance when the virus mutates. So the study was carried out in the western part of Kenya in a region called Kisumu, Nyanza province, which was previously called Nyanza province, that has the highest rate of HIV burden. And what we did was we wanted to use existing gene expert machines. These are rapid point of care diagnostic assays, or I should say near point of care, because they still require being in a laboratory. And what you do is take a blood sample, spin it, and add it in here. And within 90 minutes, you can get a viral load result back, as opposed to the traditional method, which takes several hours of turnaround time. So the company Cephia developed Gene Expert largely for TB diagnostics. So it has been fairly well used in low middle income countries. And then they developed all these other different tests that you can test on that same platform. So we were going to we leveraged this existing platform. Our goal was to determine if the point of care instead of the traditional way of viral load testing and then doing drug resistance testing could improve viral suppression among the children. And we enrolled, I'll focus on this side of the slide, we enrolled between March 2019 and December of 2020, so right at the midst of the COVID-19 pandemic at 5 government facilities in Kenya. We enrolled children 1 to 14 years of age, and they were randomized 1-to-1, stratified based on the age groups. And so here's like a flow diagram that shows who was excluded from the study and how many had the primary outcomes available for analysis. And our outcome was primary outcome was viral suppression at 12 months after enrollment. And so what we found was in the intervention group, the viral suppression at a cutoff of 1,000 copies per ml was 90%, about 90%, and it was about 92% in the control. So it was not better in the intervention group. When you use a slightly more strict threshold for viral suppression, so you drop it from 1,000 to 40 copies, which is what most high-income countries use, 40 or 50 copies, then the viral suppression drops closer to 75%. It still wasn't different between the two groups, but now you can see more children have some amount of viremia. These are some of the drug resistance patterns we detected. And so when the virus, like any living thing, is mutating as it replicates, and so when you have suboptimal use of the medications, you can start developing resistance. And so these ones in the blue are some of the major medications we use for treatment of HIV, as well as those in the orange. And so this is highly problematic when the most common drugs we're using are the kids are starting to have resistance to. And we did this component of working with the clinicians to help them manage those children who had drug resistance. And a lot of them nearly have required a regimen change. Most of them had it done, and those who had the regimen change were, some of the regimen changes were outside of our recommendations, and that many of them that did not require regimen change were on this one class of medications called protease inhibitors. So they're really potent class of medications, but they have so many side effects that we really don't like using them in adults or children if we can help it. So in this randomized control trial, we found no difference in viral suppression. That point of care viral load was feasible, as was drug resistance testing. While it was high at a cutoff of 1,000 copies, I showed you that 75% still had non-suppression if we used a lower threshold. Additionally, if we looked at the whole time point from when we enrolled them, so start at month 0 and then at 12 months, we measured it every 3 months, and I didn't show you that data, but 25% of children had a blip where they were not suppressed during that time. Now I want to tell you about our parallel study called Opt for Mamas, where we were working with pregnant women. We often joke about these studies that the best thing that came of our studies were our logos, because neither of the two studies actually worked or showed efficacy or effectiveness, but they are pretty logos. So in our Opt for Mama study, we did a parallel study where we were looking at the impact of point of care viral load testing, and our primary endpoint was 6 months postpartum. So now, because it's in pregnancy, we're following them during pregnancy, at delivery, and then every 3 months afterwards. We did follow some of them longer, but our primary endpoint was 6 months postpartum. And we did the same qualitative and cost measurements. So we enrolled 820 women. We followed them for 6 months postpartum. And this was a parallel cohort study. So we had a pre-intervention group that we followed. And once that group started later in time, we started the post-intervention group that got the intervention package. So similar flow diagram for this group where about 400-ish were available for the primary analysis. And here, similarly, we did not find that the intervention, which was the point of care viral load testing, made any difference. So about 98% of the women were suppressed at 6 months postpartum, as were 97% in the control group. If you drop the threshold from 1,000 copies down to 40, like we did for the kids, still 90% of women are virally suppressed. So actually pretty darn good. And you may remember, for those of you who've worked in this area, the UNAIDS has set the threshold to get 90% of people who are taking treatment suppressed. So this group is actually hitting that target. Some of the other work that we've done in this larger umbrella that I'm calling Upward Studies, we've done qualitative data collection. So we've worked with patients, caregivers for those on the children side and Up for Kids, as well as providers and policymakers to understand how they perceived and experienced the intervention. So we have a paper published on use of point of care viral load testing as well as drug resistance testing. We also use this as an opportunity to implement a novel point of care HIV drug resistance assay. It's developed in collaboration with bioengineers at where I was before at University of Washington that uses a lateral flow assay. So that's kind of like the urine pregnancy test. If people are aware, you pee into a cup and then you dip a strip of paper and the solution gets soaked up and it creates these bands of line that tell you actually COVID tests. I should use that as an example. We're all familiar with the home based COVID test. So it's like that, using that type of technology. So we did a field implementation. We also tried to understand the cost of implementing these different interventions. I'm going to switch now to pharmacovigilance in pregnancy work that I've had the fortune to be involved with. So we've been able to do this work for the MANGO study. It stands for Measuring Adverse Pregnancy and Newborn Congenital Outcomes. Again, over 1 million children are born to women living with HIV each year, yet the data on the HIV medication, so ART, and adverse pregnancy infant outcomes is limited. And this became a major issue in 2018 when a particular medication used for HIV treatment called dolutegravir seemed to show an association with neural tube defects, which is a particular type of congenital anomaly when other groups did not have that signal. So that really was a big deal. And so we wanted to study this a little more in Kenya, and we proposed doing work at the second largest hospital in Kenya called Moi Teaching and Referral Hospital. And so we started doing some data collection on the pregnancies, the exposures, drug exposures they have, and the delivery outcomes. So we followed women from pregnancy to delivery. And for those who are delivering not at the facility, we would do community tracking for them. Then we collected data for all the women who are delivering at that site who weren't in our pregnancy cohort. And then we would do photographs of infants who were born with major congenital anomalies with consent and discuss them with geneticists to classify those. And so this is a little bit older data, but from when we started in September 2020 through January 2023, there were about 15,000 deliveries. The prevalence was about 5.5%. 96% of those who were following the prospective cohort, the first one, had delivery outcomes, and we had detected nearly 200 congenital anomalies and the neonatal death, which is death within the first 28 days of birth, was about 10%. A little more information on, for example, C-section, emergency C-section, stillbirth, preterm birth, etc. outcomes. These are some of the specific anomalies that are detected that we've been able to present elsewhere. We expanded this collaboration to include colleagues from South Africa. Their program is called B+, and they actually were doing this already before we got started, and we learned a lot from them. So this is a good example of a South-South collaboration that we were able to leverage. And so theirs is called the Western Cape Pregnancy Exposure Registry. It's a prospective cohort that's based out of Cape Town and surrounding area in South Africa, and their aim was the same. And so what they use is a primary care facility It's a specific one that they label MOU. And the women deliver there or at any of the nearby hospitals, and they're able to link the record from their electronic health records. So it's one of the few places that has a province-wide electronic health record repository. And by connecting with all the different places where there are electronic health records collected, they're able to record all the exposures and outcomes for their pregnant person. So this is sort of an ideal setup where you can leverage existing electronic health records. Some of their outcomes. So in a comparable time period, they followed nearly 36,000 women. And these are some of the distribution of the adverse outcomes you can see here. These are another set of studies that have come out of Ringo project. So there is a study called Josie, which means coupling. So it's a study that looks at mother-infant diet outcomes of HIV testing and retention in care. Tabiri, which looks at neurodevelopmental outcomes of children exposed to mothers with HIV. This one we just call our congenital anomaly supplement. It's trying to understand the clinical care needs of families with children born with congenital anomalies. So as you can expect, this is quite distressing, but it's particularly distressing in a low middle income country setting where support for children born with congenital anomalies, often with lifelong disabilities, are not well supported. So I'm really proud of this work as we're trying to figure out how to provide better and holistic multidisciplinary care to these families. There's another colleague who's implementing what we call DAP-P. This is the desire to avoid pregnancy questionnaire, and she is an OBGYN who's adapting it for postpartum fertility intentions and contraception uptake. And I want to point out, Brienne has joined our team to do some of the analysis on the first iteration of this questionnaire. We just called it DAP, D-A-P, that we implemented with women of reproductive potential in Kenya. We have a concept on syphilis to understand what the care continuum for syphilis looks like among pregnant people. Also to look at hypertensive disorders in pregnancy. We have another concept that we're working on right now to understand climate's impact on pregnancy, so extreme weather events and its association with adverse pregnancy outcome. Okay, now I'm going to transition to the last bit of my talk and talk about contraception, which is actually about preventing pregnancies. You know, up to anywhere from 1/3 to 2/3 of pregnancies worldwide are sometimes undesired or unwanted. And so what better thing to do than to prevent those pregnancies in the first place? And that is one of the 4 pillars. If you remember at the very start of the talk, I talked about the global elimination plan that's worked on by all kinds of international entities. It has 4 pillars, and one of the 4 pillars is family planning to actually prevent unwanted pregnancy, undesired pregnancies. And so this work was actually my very first bit of work I got involved with. And it was looking at these different types of contraceptive methods, of which something called implants. They're not very popular in the US, but far more popular in low middle income countries. They're rods that are inserted under the skin. And so they are the most effective form of contraception. They're definitely the most effective form of hormonal contraception. So they're really great. They suppress ovulation right away. You don't even, it's not like OCPs where you have to wait for the next month cycle to feel confident that you're being protected. They're reversible immediately when you take them out. So unlike DMP or Depo shots, which depending on how long you've taken them, it takes a long time to reverse that effect. Your fertility returns immediately upon taking them out. And like I said, you know, 10-15% of women living with HIV in sub-Saharan Africa are using implants. And so we did this work where we're all, again, based in the western part of Kenya with a program called FACES, where we followed women through their electronic health records to understand their pregnancy rates. And so what we found was if you're using a particular type of antiretroviral therapy called nevirapine, um, as opposed to efavirenz, you had lower risk of pregnancies. Let me say it the other way. If you're using efavirenz, you had a higher risk, which was so this actually came to me when an OBGYN colleague asked, "Hey, we just are seeing a couple pregnancies on women using implants and efavirenz base. Are you aware of this?" And that's how we started looking at this data. But interestingly enough, when you look at the real world data, when women are using Depo or DMPA, their pregnancy risk is actually higher at baseline, regardless of what regimen you use. And that's because DMPA has what we call user action requirement. So you need a shot every 3 months, as opposed to an implant, which you place, and it's good for 3 to 5 years, probably even more, kind of like the IUD, which is only approved for a certain period, but we kind of know it's good for many more years than that. And so here we realized, because some of the ministries of health, when this first became reported, were like, oh, no, you can't use efavirenz in women who are using implants, or if women are using efavirenz, you can't use implants. Well, the honest truth is, if you take a more holistic step back, it's actually still more effective than other combination options. So it's really about asking women, what do you think with this information, and which method or ART regimen do you want to use when options are available? We replicated this work in a larger collaboration with another group called East Africa IDEA Consortium that had FACES data, but also this other group called AMPAP that had far more women. And so we showed very similar findings where the efavirenz risk is higher, but it's still lower than other hormonal contraceptive options. And I'm particularly, these are some additional things where we wondered if higher weight or BMI had an effect, longer duration. This was not the case. We also looked at pharmacogenetics being associated, and some of these are associated with having um, uh, higher efavirenz levels or metabolizing it slower, which then puts you at higher risk for this drug-drug interaction. I was really grateful to our paper was published, I think, September of 2015, and by October, the World Health Organization had included our work in saying that women can continue using progesterone-only implants. It was really gratifying to have this kind of policy impact so immediately. Several country ministries of health never implemented or reversed its prior restrictions, which is really great from a decision-making perspective, in that we're giving women and providers choices to choose from. So, when you have this drug-drug interaction, you're stuck between a hard place and a rock. Can you change to contraceptive? Okay, IUDs are not that acceptable in many low middle income countries or available. Placement is harder. The sterilization equipment needed to place the IUDs are not always available. DMPA shots, on the other hand, are one of the most popular contraceptive methods used. Could we shorten the duration of the implant? Like I said, there are two types that are good for 3 or 5 years. Could you use it for less when the concentrations are still high in the body? Could you use two of them? So we did some of that work. Shortening the implant didn't seem to make a difference. There was still a higher risk throughout. When you double the dose, so the 300 milligrams as compared to the blue line, which would be in women without ART exposure, was still not a good option. So then can you change it on the ART side? Can you lower the dose? Can you choose another ART regimen? So this is a study showing that you could use a lower dose. So the standard dose had been 600 milligrams, but if you used a lower dose, it had the same effectiveness. And so we did this PK study in Kenya and showed that they are just as good with the lower dose. Then dolutegravir came on the scene in 2016, recommended by the WHO as an alternative first line of treatment. And in 2017, countries began the rollout. And then, as I told you, in 2018, just as it was becoming first line, there was a scare that this drug was associated with neural tube defects, a type of congenital anomaly among infants exposed to mothers who were using dolutegravir. So the WHO said that, please caution, adolescent girls and women of childbearing potential should not receive dolutegravir, and if they are getting dolutegravir, to use hormonal contraception. And this was based on basically no data at that time. And ministries of health, this is the Botswana that said, you have to should use effective contraception, and if they're on dolutegravir, they should be switched to something else. The problem was dolutegravir was superior than other treatment options. So here's like the Kenya Ministry of Health, where it says use efavirenz. Adolescent and adult men on efavirenz should be transitioned to dolutegravir. So as you can imagine, this did not, oh, sorry, it's in the background. It's meant to be a picture of women protesting at one of our international HIV/AIDS conference, saying, you can at least see that, they're saying young women demand dolutegravir, my body, my choice. This, can resonate with a lot of the reproductive health justice movement that we've had in this country. So women are saying, like, don't make these choices for us. Educate us and give us, the tools needed to make decisions. And so we were able to look at this drug-drug interaction from a pharmacokinetic study point of view and showed that there was no significant differences between those using dolutegravir. And a really interesting part of the policy side of this is, so the countries, as I showed you in 2018, made these decisions like, okay, be careful, there's an association between neural tube defects. And then, as you can see, the top lines, the gray are men over age 50, and the green is females over age 50. So they started getting this new medication that was better than what we had available for low middle income countries. And then by December 2018, WHO says, okay, use it, but not for all women. And then by middle of 2019, WHO says, okay, go ahead and use it for all. We have, but I didn't share with you, there was follow-up data that then said, whoops, sorry, that initial signal isn't exactly what it was. We think it's okay to use it. But even then, you can appreciate that females of reproductive age, 16 to 49 years of age, did not get access to this new and better drug for a long time. So it's a important point to make, that sometimes policy decisions can last even when they're reversed and have unintended consequences. So some of our other work, also inspired by this issue, was a project called Chaguo Langu, which means my choice in Kiswahili, a mixed method study to understand women who were started on dolutegravir and then were asked to switch their regimens or asked to start a effective contraceptive method. And qualitatively, what we found was, there were women, widespread. Some women were saying, my provider knows best. They can tell me what to do. Others who were saying, no, this is my body, my life, my decisions. Don't just change my HIV treatment or family planning options without talking to me first, without telling me and informing me. And uniformly, providers felt underprepared to do the counseling that was needed. If any of you have worked in low middle income country settings, particularly in sub-Saharan Africa, a lot of the providers there see nearly 100 patients a day. So we're not talking about 10, 15, which is more of the usual cadence in the US setting in primary care. Maybe in private practice, it might be something like 20, but these providers are seeing upwards of 100 patients a day. So for them to do this kind of nuanced conversation is really hard. We've also received some funding to do work on long-acting injectable ART. So this is really exciting because for the first time we have a oral daily pill options. Instead of taking pills every day, you can get an injection eventually that's used every 2 months. And it's called Cure Free or Live Free, a name that our youth advisory board offered us when we started this project. In the qualitative study in Kenya, we've looked at all the multi-level barriers and facilitators to this new novel way of treating HIV and highlighted the role peer mentors have in this process. We're also now doing a pharmacokinetic study in Botswana to look at drug-drug interactions between this injectable HIV treatment option, one component of it, which is also in PrEP, and hormonal contraceptives. So I am really excited to stop at this point, and I'll just give you some thoughts that I have thought about as opportunities. As many challenges there are, I think we're at a place in HIV where, I use this cartoon in a comical way. We've had this public, quote unquote, public health approach. And really, like, my question is, whose approach is it? Because it's really, the shirt is meant for males, and we're asking pregnant women or pregnant people to wear those same shirts. These needs shift over the cycle. The needs early on, maybe preventing pregnancy, and then you get partnered and you actually want an infant. And you're still trying to prevent pregnancies in between your pregnancies, because we know that's important for both the mother and the child. And then as you age, you sort of hit another set of priorities and needs. And, I'm a big proponent of trying to support informed choice, even when we don't have all the information, and using a shared decision-making approach. The other thing I wanted to emphasize, for me, maternal child health is really an important platform, because no one opposes people getting pregnant and having safe pregnancies and healthy babies. We all want that. And so it's a really important platform to use for other things that are also related, in my opinion, to HIV, like STI. So we know, for example, we have a global resurgence of syphilis in pregnancy, and congenital syphilis is alarmingly high again. And so we need to do more work there, as well as in gonorrhea and chlamydia. It's a platform to reach other people. So there's a lot of work that's actually happening in male involvement in pregnancy or family planning. And it becomes a way to reach the larger family, the community, for their health. It's also an important time to think about other dimensions of health, like mental health. And I include intimate partner violence, which upwards of a third women globally will experience. And so for me, it's been a platform to think about those other elements as well. And include women in research, because representation matters. And I just wanted to share what I've presented to you is some of the work in the first two buckets of my team's work. But what I didn't share with you is a community-based participatory research project with African immigrants. This was started previously in Seattle area, and now we're starting this work with, for example, Brienne's help in Birmingham, reaching out to faith-based communities to do HIV testing and stigma reduction. We also have a stream working in what started with HIV and COVID to look at social determinants of health in the US. And we're now expanding it to non-COVID topics, as well as structural and policy determinants. And this body of work largely leverages electronic health record data that's collected in the US. So I'm going to stop at this point. Here's my email address. And what I really want to do is understand a little more about each of your interests and what you've been thinking about maternal child health.
Thank you so much, Dr. Rena Patel. It's Annie Glover as the one on camera. So we will give opportunity to those who have questions and have want to say a bit more about their interests in maternal and child health, and open discussion with Dr. is an opportunity for us to learn more from her and also have some guidance, orientations, and advice from her also. So, floor to you, Mrs. Annie Glover.
Hi, thank you so much. My name is Annie Glover. I'm a new assistant professor in public health, health policy and organization. And my background is in maternal health, mostly. Have been working in maternal health in Montana. Um, I also did my PhD and my postdoc in the Congo on safe abortion care, and did some HIV work in Uganda previously. And so I'm really interested in setting up some research at UAB on HIV. And a lot of my work has been on perinatal substance use. And so I'm really interested in looking at substance use as a essentially comorbidity or complicating factor for adherence to treatment, as well as we have had, as you were just talking about, a huge congenital syphilis epidemic in Montana recently, with numbers that look like we're in the early 20th century. um, so I'm just really interested in all of your work. So thank you.
Amazing, Annie. That is something I really want to stress to folks, because I think historically global health came from, a body of work or a paradigm where people are like, oh, you go live and work abroad. Um, where I feel like increasingly, potentially because of increased globalization as well as like technology, like we're all on Zoom anyway now. And all my international collaborative meetings happen by Zoom now, that it's really easier to do work that addresses the fundamental issues that are both applicable domestically in the US as well as in low middle income countries. So a lot of these themes, Annie, that you've raised, whether it's abortion, so Kenya, technically it is legal uh, in most circumstances, like unfortunately, arguably more than it is in the US, many states in the US now, but there is still really high stigma against
Mhm.
getting abortions. And so it's yeah, really interesting element where more work needs to happen to understand, how they're happening, um, who's seeking them out, how do we, promote the safety of those who are terminating their pregnancies, et cetera. Um, and that clearly is applicable in the US now more than ever. You take the syphilis, it's on rise here in the US as well as in other countries. Um, some of the other themes that you've mentioned again. So it's really great, Annie, that you've had both experiences. And I want to stress that I think that those like are um bridgeable connections. Like we shouldn't think like, oh, I only work domestically or I only work in Congo or Uganda. I think some of these lessons are transferable. They of course need to be adapted or individualized for the local context, but definitely that's really great work. Yeah. Um, uh, Annie, please feel free to reach out. And I'm not the only one working in the space at UAB. There are colleagues in OBGYN as well as even in my ID division who work in pregnancy and maternal and child health. So that'll be awesome to talk
Yeah, I
more.
find that you have low resource settings in rural environments, and they can be in the US and they can be in sub-Saharan Africa, and you're going to use a lot of the same approaches, because there's a lot more in common than there are differences sometimes.
Exactly. Yeah, Annie, stay tuned. I think so I'm part of a group at the Center for AIDS Research, CFAR at UAB. And we're trying to gear up for a pilot funding request sometime in the next 12 months, where we're asking people to do just that, to make a connection both locally, whether that's Montana or Alabama, but locally in the US, and then abroad in a low middle income country setting.